everyone. My name is Lauren. I'm here to give y'all a presentation on what a speech pathologist can do for you in your medical journey. I do not have any financial disclosures. I am an employee of Ochsner Health System here in New Orleans, and I serve on our Huntington's Disease Multidisciplinary Clinic. I've been with the team for about 4 years.
How many years?
About 4 years.
Oh, I thought you said 40.
No. So these are what we as speech pathologists consider the big 9, the areas that we treat, that we're responsible for in our scope: articulation, receptive and expressive language, fluency, voice, cognitive communication, hearing, swallowing, augmentative communication. These are the ones that I'm really looking at with Huntington's disease: articulation, receptive expressive language, swallowing, voice, AAC, cognitive communication. And so if I put all of these things together into 3 buckets, I come up with speech clarity and intelligibility, cognitive linguistic skills, and swallowing, and that's what I'm going to mainly talk about today. So our main goal as speech therapists is to facilitate safety and comfort while maintaining quality of life in all of these areas. And when is the right time to even ask about speech therapy services? As soon as you notice your symptoms. So anything that we talk about today, those are things to bring up with your care team, your neurologist, your doctor. Anyone can kind of get you in touch with a speech therapist, put a referral in, and we can kind of take it from there and work our magic. So the first thing we'll talk about is speech clarity, which in actuality we think about that as speech intelligibility. It refers to the words that is spoken divided by how many words I actually understand. So if you're reading a 10-word sentence and I only understand 5 of those words, that would be considered a 50% speech intelligibility. We want to understand everything you have to say. Everything you have to say is important. So we as speech therapists help to facilitate use of strategies to improve your speech intelligibility. If you're going to be coming to someone like me and getting an assessment of speech clarity skills, we're looking at these areas: cranial nerve assessment, assessment of respiration and phonation, and a communication effectiveness survey. With a cranial nerve assessment, that's me looking at your mouth, your jaw, your lips, your tongue, all of these muscles and movements that you need to speak. Looking at range of motion, strength, asking you to make a bunch of funny faces. Looking at assessment and of respiration and phonation, asking you to say all kinds of funny sounds: pa pa pa, ta ta ta, ka ka ka. That's called diadodokinetics. And what I do is I divide how many times you can say certain sounds divided by a norm, and we get a certain ratio that we can kind of track as time goes on. So for me, in my Huntington's disease clinic that I work with, I take these measurements every single time I see you, and every single time we say, this is what's changed, this is what stayed the same, this is what we can do to kind of help continue to maintain your skills. We look at words per minute. How many words are you saying per minute? So maximum phonation time. Is your respiration, is that respiration coordination between your breath and your speech decreased at all? And then we look at, I always do something called a communication effectiveness survey, which is a rating scale of 1 to 4, 1 being not at all effective, 4 being very effective. And what I like about this is that it's taking into account the different contexts of speech and communication. So talking in this quiet room might not be as difficult as talking in the exhibit hall, where it might be really loud, right? And you might need to use extra body language or other strategies to get your point across. Talking with someone over the phone that you're familiar with, that's really different than talking to the pharmacist over the phone, right? That might take a little bit more practice and a little bit more of using speech strategies that we'll talk about. These are some speech strategies that I always try to hammer in with my patients. SLAP, S-L-A-P. S stands for slow rate of speech. L stands for loud speech. A stands for articulate speech, and I like to say over-articulate. You almost want to pretend like the person you're talking to is hard of hearing. You want to over-enunciate those words. And then pausing to take a deep breath. So getting into these slow, we have muscle weakness or coordination difficulties that can occur with Huntington's disease, and that impacts those muscles in speech production. So slowing down that rate of speech allows for the speaker to focus on articulating each sound with the word more accurately. Loud, increasing vocal intensity.
Can I just ask you to slow down? I can't write that fast.
Yeah, you want to take a picture of something?
Well, just slow it just a little bit so I can write.
Okay. Slowing down, taking your time to use as much pausing as necessary to get your point across and to articulate the words that you're trying to say. Being loud, increasing that vocal intensity. That also is going to increase that speech intelligibility and allowing for a more distinct projection of sounds and words. Articulation, over-articulation. You can compensate for some of those articulatory weaknesses by emphasizing sound. So like I said earlier, almost like you're pretending someone's across the room or there's a barrier in between you and they need to read your lips. You're over-enunciating those sounds and words. And then pausing. So pausing to take a deep breath, allowing you to replenish your respiratory support. When we speak, we have to have that power coming from somewhere, and that's in our lungs. That power breath comes up through our vocal folds, up through our mouth, and our mouth is what shapes the sound. So our vocal tract really starts at our breath support. If our breath support isn't coordinated with our speech, that's going to cause some difficulty with being loud enough, with being able to over-articulate. So I like this graphic at the top. If you breathe in and breathe out, you're only going to speak out on the exhale. So if you don't have as much power breathing in, you're not going to be able to say as much as you want. You're going to have to take another breath. You can see it's very rhythmical. Breathe in and speak out. Breathe in and speak on the exhale. For someone with Huntington's disease, that coordination might look a little bit more jaggedy, and so I always encourage to pause, take a deep breath, replenish what your power source is, and then keep going. It might slow you down a little bit, and it's a little bit more work on the front end, but more work on the front end is better than work on the back end. And then these are just some communication partner strategies that y'all can use. Reducing distractions and background noises, obviously, right? Those are things that we're probably gonna try to do anyway. Making sure you're paying attention to the speaker, watching that person as they talk. Let the speaker know when you're having difficulty understanding them. And only repeating part of the message that you understood so that the speaker does not have to repeat their entire message. And if you still don't understand, asking yes or no questions or having the speaker write his or her message to you can be beneficial. So all of those strategies that I talked about, like slap, go slow, be loud, over-articulate, pause, it's in theory, that's really easy to do. I can tell y'all all that and y'all can say, oh yeah, that makes sense. You have to practice it. So practicing it for 5 minutes a day, twice a day, thinking about what does my speech sound like? What kind of effort do I have to put out right now? What's my environment? Is the TV on really loud? Is that making me feel like I'm not being loud enough? Because when you have that self-awareness, you'll be able to know in the doctor's office, oh wow, they're probably not able to understand me. What are my strategies? Okay, let me over-articulate, let me pause. So that in the moment you don't have to think, oh gosh, what are my strategies? I don't know them. You've practiced them before and they've become second nature. Thinking about assistive communication and voice banking. So as we know that Huntington's disease progresses, there could become a time where functional speech is no longer present. And AAC is something that can range from a simple set of picture symbols to a full-blown communication device that actually speaks messages or words that you intend it to. AAC is never meant, AAC is the term for augmentative and assistive communication. It's never meant to replace speech, but it's meant to act as a bridge to communication. So in those times where you are exhausted or your communication partner just is so unable to understand what that is, this is something that can help decrease that burden, increase the ability to communicate with your loved one. These are just some examples. The one in the middle is just sign language. That's an example of augmentative and assistive communication. To the right is a letter board, so spelling out some words so you don't have to physically write it down. And then all the way to the left is a dedicated communication device, a speech generating device, where you press a button and it says whatever you've programmed it to say. AAC devices, they are covered by insurance. Typically, insurance covers 80%, and a secondary insurance will cover the other 20% of it. And this goes through a speech therapist. We do a full AAC evaluation in conjunction with your neurologist's orders or your doctor's orders, and we decide exactly what device is right for you. So we look at 3 different software companies and 3 different devices in each software company so that you know you're getting kind of the pick. You can choose whatever it works best for you. And then we help with all of the paperwork and funding, and usually the process is between 3 and 6 months, but it's really a great option for whenever communication becomes non-functional. And then moving on to cognitive linguistic skills. Thinking about cognitive linguistic or cognitive communication disorders are problems that have to do with communication that have an underlying cause in a cognitive deficit rather than a primary speech or language deficit. So more so in attention, memory, executive functioning, visual spatial skills, and I look at questionnaires too. So these are all areas that I assess. And I always like to note the relationship between memory and attention. If we can't fully pay attention to something, how can we fully remember it, right? Attention is the mother of memory. I always say that I can't always change memory too much, but I can change attention, and I can change your environment and the things that help you pay attention. And so it's really good to think about it that way so that you're not saying, oh, it's my memory, right? It can just be how you weren't paying attention in that moment, and that's okay. We can always go back and revisit it. Restorative therapy and compensation. So with Huntington's disease, we know that it progresses, right? If we're going to be continuing to do ongoing therapy and we know this disease is progressing, are we undoing some things? Are we spinning our wheels? Versus learning compensatory strategies and learning, well, how can I get around this? What are some new ways? How can I adapt? Usually my approach is a lot of compensation mixed in with some restorative therapy, and when I talk about strategies, we go a lot through compensatory strategies. So these are some attention strategies. Reduce distractions in the area, right? If you're needing to look at a recipe book and figure out what you have in the cabinet, that if you can make dinner tonight given this recipe, turn the TV off so you can look at it and highlight the things that you need to highlight. Look at that person as they're speaking to you. Maybe paraphrase as they're speaking. Say, oh, did I catch that right? Ask them to repeat themselves, have them write down some information, even having some visual cues to remind you to do something if you need to do something later. I'm a very big visual cue person. My back door at home has a bunch of sticky notes on it, and that's how I remember to do things. So you have to figure out what works for you. What works for me might not work for you, and what strategies are just kind of, you have to play around with it and see what's best. And these are some memory strategies. So when we think about memory, we're breaking it into internal and external memory strategies. With internal memory strategies, things that we're doing intentionally in our own thinking to improve your memory performance. It can be something like repetition, association, taking visualizations in your mind. An example of repetition could be, you meet someone, they say, oh, this is my friend Jim. Oh, hi, Jim. You're repeating it, right? That's going to make you 50% more likely to remember it. And then thinking about external memory strategies, things that are not in your mind, letting technology do the work for you, right? So even taking a picture of a slide, you can go back and review that later. Timers and alarms. I have Alexa reminds me every day about my medication. I can't remember to take my medication, so Alexa does it for me. I'm letting technology do it. Siri can do the same thing. Reminders app in the health app on an iPhone, Google Tasks, in general medication, like having a weekly medication sorter, putting that in front of your coffee maker so that every morning if you're gonna get coffee, you know that that medication sorter is right there and you're gonna have a cue to take your medication. And then old-fashioned pen and paper, right? Making lists, having a planner, making a calendar. So this is a couple of the ones that were on the last slide. The RAP method. Write it down, make a list, utilize a calendar. I always say that, it depends on kind of the person that you've been your whole life. Have you always been the person that needs to write something down? I have to write everything down, or else I don't do it. My husband's the opposite. He knows that he has a dentist appointment on April 3rd at 2 p.m. I don't know how he knows that. He just doesn't have to hold it in his mind like I do. And you have to know yourself. So before your disease is progressing, what's your preferred method of recall? And after, you might have to tell yourself, hey, do that preferred method. You might not automatically do it. Repeating is another strategy, like I said earlier. If you meet someone and they say, oh, my name's Jim, likely you're not going to take out a piece of paper and write Jim right there, right? But if you say, oh, hey, Jim, oh, let me make an association. My boss I used to have a boss named Jim. He was a really nice guy. You're probably way more likely to remember that information because you actively chose something to hold on to. So that's that example of association, connecting that desired information with something that you already know. And then picturing it. Try to mentally picture what you're trying to remember. Taking a mental picture is great. Also, know your strengths. I'm not great at visual memory. You might be great. That's something you might be able to really hone in on. But these all strategies that might not come as second nature. You have to tell yourself to do it. So that active decision making of when your sister says, hey, do you want to go to lunch next Tuesday? Yeah, great, I think I'm free. Can you text me about it? Or can you call me later so I can put it in my calendar? Make that decision, how am I going to remember this for later? Because right now it's in the top of my mind. Tomorrow it might not be, and I might not remember to write it down. So what do you need to do in that moment? And these are executive functioning strategies. So executive functioning is putting it all together, taking what you've had, what planning and task initiation, and actually going through with it. What's the first step? What's the second step? How do I complete this? Goal plan action review is a really good strategy to use. It lists out what's my goal? What do I have to do? What's my plan to get there? What is steps 1, 2, 3, and so on? Let me do the plan, then let me review it. Did I stick to it? Did I finish it? Did I say that step number 1 was only going to take me 15 minutes and it really took me an hour? Am I not going to be able to finish this task today? Do I have to push it off till tomorrow? Helping you set up your own expectations. And then the mental rehearsal really kind of goes in with that too. So thinking through it out loud almost and doing some kind of verbalization as you go can really help keep you on track. And then moving on to swallowing. So normal swallowing consists of 3 phases: the oral phase of swallowing, the pharyngeal phase of swallowing, and the esophageal phase of swallowing. In the oral phase of swallowing, the food or liquid is drawn into the mouth. Your tongue gathers that food or drink. It's mixed with saliva. It's broken down into little pieces and kind of forms a ball. That's called a bolus. The tongue throws it back into the throat, and that's the end of the oral phase of swallowing. Moving on to the pharyngeal phase of swallowing. The bolus, the thing that we swallowed, moves down the throat with the help of those muscles that we have in our throat and the pressures that we generate as we swallow. Our hyoid bone lifts up, and our vocal folds slam shut and move out of the way of our airway so that your esophagus can open up. When that happens, your bolus passes into your esophagus, and then the pharyngeal phase of the swallow is done. With the esophageal phase, that's going into the stomach. That can have some complications with reflux, and those are some things that we kind of manage, but mostly we would redirect you to your gastroenterologist. The pharyngeal phase and the oral phase is really what we think about, what I think about a lot with my Huntington's disease patients. Is swallowing comfortable for you? Are you coughing and choking with eating and drinking? All of these questions are things that we like to think about. So any interruption to those phases, the oral, the pharyngeal, the esophageal phases, is called dysphagia. I don't know if anyone's heard of that term. It's just difficulty swallowing. And our main goals is to preserve quality of life, swallow efficiency, swallow safety. Swallow safety, that's kind of what I just talked about. Are things going the wrong way? Do you feel like you're coughing or choking when you're drinking, when you're eating? Maybe not all the time, maybe only sometimes, maybe only with certain consistencies. Swallow efficiency kind of refers to, are things going down? Are they getting stuck in certain areas? There's natural cavities in your throat that food is supposed to collect in. They just need to empty out. But are those muscles kind of compromised, and is that not happening anymore? And what are some strategies we can do to mitigate that? And those two things together, I think, make up quality of life. So if you're not comfortable with swallowing, if you're coughing all the time, if you feel like it's just a chore, that quality of life is going to go down. Subsequently, if I'm telling you, hey, you can't eat this, that your quality of life might go down too. So it's really a partnership between us to discover what is best for you. And then with what to look for, a lot of people might say, my food's going the wrong way. I just don't feel like eating anymore. I cough when I drink my water or my Coke. I feel like that tougher food, that's getting stuck in my throat, but I really don't have a problem with anything else. I'm only having trouble swallowing liquids. I have people tell me that all the time, and those are ways to kind of keep your eye out for, is there some swallowing difficulty going on? Also looking for throat clearing or coughing with foods or drinks, any unexplained weight loss, pneumonia, wet vocal quality. So almost like if you want to tell someone like, oh, clear your throat, that sensation of that voice being wet, that's a sign that something's going the wrong way. It is an indicator that you might need to see a speech therapist so we can do some testing. So assessment for swallowing looks like a cranial nerve assessment. Like I said earlier, looking at all of your strength and mobility in your jaw, your lips, your tongue, your soft palate, your cheeks, all of those areas. Your cough response, is your cough really strong? Is it weak? Looking at all those areas, range of motion and strength. I always do a clinical swallow evaluation, which is me giving you a couple things to eat and drink, which I always give 3 ounces of water. It's called the Yale Swallow Protocol, and it's a highly sensitive test to identify those who are at risk of needing further testing. So here's 3 ounces of water, drink it all without stopping. I always do that, and I always do some type of puree, like an applesauce or a pudding, some type of cracker. I like to do peaches because it's something that's dental soft in a liquid consistency, so it's a little bit harder to navigate in your mouth. I try to do some of those complicated things in a clinical swallow assessment, along with an Eat 10 survey. This survey, an Eat 10 survey, it's up here. It's a survey on a scale of 0 to 4. 0 is no problem, 4 is a severe problem. It asks questions like, my swallowing problem has caused me to lose weight. It's interfering with my ability to go out for meals. It's painful. I'm coughing when I'm eating. I'm stressed out by swallowing. It's taking extra effort to swallow pills or to swallow liquids or to swallow solids. And so I really go through these 10 questions in a lot of detail and figure out what's the trigger here, what's the problem going on. And while I'm watching that person eat or drink, I'm taking notes and looking for those clinical signs and symptoms of aspiration, like I was saying earlier, coughing or choking, that wet vocal quality, even those like small throat clearing, that could be a sign that something might be kind of getting in the wrong way. Maybe not that we're having gross aspiration all of the time, but a little bit of something going the wrong way sometimes. We still want to check that out. And then compensatory strategies and diet modification. These are things that we're always looking at after we're doing, or in the middle of doing this assessment. So what are some compensatory strategies we can use potentially that might help with facilitating a more efficient swallow? So like taking a liquid wash, taking a sip after you take a bite of something that might be dry or crunchy. Alternating bites and sips. Take a bite, take a sip, take a bite, take a sip. That can be clearing of all of those cavities in your throat that is naturally going to hold on to some of those foods, but that muscle coordination just might not be enough to empty it out after that first swallow. So that liquid wash can really help to empty that all out. I'm always going to say small bites and sips. It's a really big thing, and slow rate of eating. I think implementing those 2 things are probably one of the biggest things with the Huntington's population. If you're able to slow down and think about, what do I have to do next? Let me take a very small bite of this. All right, let me go to this sip of water. You can manage that meal a lot more effectively and efficiently compared to lots of choking or coughing or kind of just getting frustrated in the middle of a meal and not finishing it. Some other things we might do is like a head turn to the right or to the left to maybe close off a weaker side if one side is a little bit more weak than the other, or even a chin tuck, putting your chin down when swallowing. That can sometimes help with facilitating a more efficient swallow. Sometimes it can be not the right thing, and sometimes it can actually cause aspiration or more harmful things. And so that's what kind of gets me into my next slide that I'll go into, which is assessment, objective assessment. But I have diet modification down here, which I use a framework called the International Dysphagia Diet Standardization Initiative, and it's a framework of various consistencies with foods and drinks. My goal is, for the most part, to use compensatory strategies over diet modification. I rarely want to say you can't eat this, or you have to eat pureed food or nectar-thick liquids. I want you to eat whatever you want, as much as you can, maybe with the use of compensatory strategies. The earlier we can use those and train them, then as time goes on, it becomes second nature. So we don't have to use, diet modification strategies like pureeing foods or thickening foods. So I talked about all the things that I might do in my clinic, giving a cranial nerve assessment, looking at all those muscles, that survey, giving you some things to eat and drink. After I do that, I decide what is the best test for you. I do both of these tests. One is called a modified barium swallow study. One is called a fiber optic endoscopic evaluation of swallowing. Has anyone ever had one of these? Couple? Yeah. They're not the most fun, but they get the job done. So a modified barium swallow study is sitting in the radiologist suite in the hospital. It's an outpatient procedure. It usually lasts between 20 to 30 minutes, not too long. The radiologist is usually just turning on the fluoroscopy machine, and the speech therapist is giving foods to eat and drink. We try to do the things that y'all are telling us are giving you the most trouble, but we have a protocol that we use with my team, and we physically watch, where is this food going? Is it going the wrong way? Is it going the right way? Are some things going the wrong way? And what muscles are affected? There are certain muscles that are affected within the swallowing mechanism, and we can kind of decide what's safest for you. That other picture, when you're seeing an endoscopic view, that is another assessment that I do. It is a camera that goes in your nose, and then it glides to the back of your throat, and I give you a bunch of things to eat and drink. I dye it all green or blue because your throat is kind of the color of your hand, so if I use clear water, I wouldn't be able to see where anything went. And you can see in this picture that that green is kind of going into that hole. That's the airway. That's going the wrong way. That is something that we really want to be concerned about. It's not comfortable, and it can also lead to pneumonia. So these are the gold standards. Using them together is actually considered the platinum standard for assessment of dysphagia. Either one works for me for the most part, dependent on how severe chorea is for this patient. I might choose a modified barium swallow study because having a lot of movement and something in your nose might not be as fun. If your chorea is a little bit more controlled, we might be able to do it, but both of these tests are really, really the best gold standard that we have for assessing dysphagia, and it can help come up with a plan. And so this is what I was talking about earlier, the IDDSI framework. IDDSI, International Dysphagia Standard Initiative. It's a framework that provides a common terminology to describe food textures and drink thickness. It includes food and drink descriptors along with instructions for easy, reliable, accessible methods to test foods and drinks. They have a really good website that has very easily digestible information. It's just iddsi.org, and it has really good printouts that you can print out as PDFs or even screenshot, and they have great recipes, foods to avoid, certain, like how it says regular and easy to chew, it can kind of distinguish that. What are things that are easier to chew, and having it on a list can be really helpful. So after I do that FEES, that swallowing assessment, modified barium swallow study, whatever we choose to do, if we decide that, thin liquids are not safe and maybe chewed foods are not safe, they're going the wrong way, that might take away some of these options, right? We might have to recommend a pureed diet and mildly thick liquids, but that's all it is, a recommendation. And it's your turn then to decide, okay, what is best for me? Let me take all the education that I've gotten, let me see what my speech therapist says, what my doctor might say, and let me make a decision. Which brings me to the pillars of aspiration-related pneumonia. I could probably talk on this for days. Like I said earlier, quality of life is a big thing in dysphagia. And our main thing is we don't want you to develop pneumonia, right? We don't want anything like that. You don't want to have to battle that in addition to everything else y'all are already battling. So Dr. John Ashford did some research in 2005 and determined that there are 3 pillars that contribute to aspiration-related pneumonia. Oral care, so brushing your teeth. Are things actually going the wrong way? Are you having aspiration and physical mobility? And a compromised immune system. So if all of those things are not present, that person is way less likely to develop aspiration. And subsequently, if aspiration is less of a risk, is it less of a risk than malnutrition and dehydration, right? You can have whatever you want, right? Let's just be safe about it. Let's eat with those compensatory strategies that we talked about. Let's use slow rate of eating and small bites and sips. This is just a cool chart, I think, that looks at a risk predictor with pneumonia. So if you'll see at the bottom, if you have a compromised immune system, you have poor oral health status, you have aspiration that's occurring, that's going to be the person that develops pneumonia, right? So if you're up, you're walking around, you're able to brush your teeth 2 or 3 times a day to decrease those bacteria on that oral pharyngeal surfaces, you're way less likely to develop pneumonia. Now if I pair that with someone who might be bedbound, they cannot brush their teeth, they don't have that physical mobility maybe, or they can't remember to do it, and they're having things going the wrong way. When they wake up in the morning and grab that cup of juice next to them and take a sip, all that bad bacteria from their mouth is traveling into their lungs if it's going the wrong way. That's going to be the person that's way more likely to develop pneumonia. So if there's one thing you remember, brush your teeth as much as possible and be active and move as much as possible. You're going to be at a way less risk to develop pneumonia.
What does brushing teeth have to do with pneumonia?
So if you have bad bacteria in your mouth, like we all do, we have to brush our teeth. If you take a sip of water, let's say, or you take a bite of something, and it goes the wrong way, you're taking that bad bacteria with it into your lungs, and that it can fester and develop pneumonia.
Can you explain what aspiration is?
Yeah, whenever food is going the wrong way, aspiration is whenever food or liquid is going from your mouth into your throat, and there's something that kind of gets disconnected, and it goes into your lungs. So that picture that I had showed right here, aspiration, that green dye, you can see it traveling past the vocal folds into the lungs. That's what's considered aspiration. It's a result of dysphagia, like we had said earlier. Does that make sense? And so, what does this all mean? I think that knowledge is power, so you know what to look out for. There's no surprises. That's kind of the good thing of knowing all of these kind of risks and strategies that you might need to use one day, because you can put them into practice now, and you can start using these things now so that one day it's not a surprise. So I always say set strategies out now so that they become second nature. You don't have to think about them. Does anyone have any questions? Yes. So the question was about voice banking, and if at what timeline in the Huntington's disease process we should look into voice banking. Voice banking is it's banking your voice, so that's the term, where you record yourself with a lot of different phrases and words and sentences, and it builds you a voice that could one day be put onto a computer system, so that whenever you touch the, can I have water please, it's not a robotic voice, it's a voice that's synthesized to sound more like you. That can be done at any time. Unfortunately, insurance does not cover that at this time. However, there's some grants that might be able to be applied for. I would say as early as possible, and honestly, just recording your voice kind of gets you somewhere too. So having just any recordings, like having a recorder from Amazon and recording yourself reading out loud, stuff like that, that can be potentially used in the future. But Anne-Marie is our social worker at my Huntington's clinic. So if any social worker at your Huntington's clinic can connect you with a speech therapist, they can help to initiate that, get the ball rolling. And we have certain, I know the Teen Gleason Association that works a lot with the ALS population, they offer those services as well sometimes too. And what's your other question?
My other question is,
Yeah, so
might be totally out of your...
I can offer something. So the question was about like phlegm, or like what we call sometimes like a globus sensation, a sensation like, oh, something's right there, and kind of what we can do about that. So that could be a bunch of things. I can't say exactly what that might be. Sometimes that my mind rings about reflux. Increases in reflux can actually cause that sensation. A strategy that I like to say is take a sip of water or just swallow and swallow hard. Push your tongue into the roof of your mouth and squeeze your throat when you're swallowing. That's a laryngeal repositioning, and most of the time it gets rid of that sensation. As time goes on, the more we cough or throat clear, that's going to send a signal to our brain that we need to do it more and more and more. So we're kind of tricking ourselves into this bad habit sometimes. Now, sometimes, and most of the time, there is that phlegm going on too, and that's something that, you might have to have designated times of the day where oh, this is just my time that I need to cough up phlegm. But that laryngeal repositioning of swallowing hard can get rid of that sensation a lot of the time.
Did you say pharyngeal or laryngeal?
Laryngeal. Yes. So I wouldn't say that reflux is a symptom of Huntington's disease. However, some strained vocal quality can be a symptom of Huntington's disease, kind of with that speech, the muscles I had talked about earlier. Some of those muscles are involved with voice production too, and some of that some changes in that strength and coordination can kind of result in that hoarse speech, or what we call dysphonia. But the combination between reflux and that might make it a little bit more harsh or rough sometimes. But a speech therapist can absolutely help with some exercises to decrease that strain. Yes. We potentially could. So we can help with generating that subglottic pressure. So there's some exercises we can help with that. I would say, so the question was, I'm sorry for not repeating the question. It was about if my partner, he hasn't had trouble swallowing before, some new trouble swallowing has occurred, and he's having some difficulty coughing. So that's actually part of my assessment when I assess someone. Is your cough strong? Is it weak? Can I elicit a cough at all? And there are some things that we can do to help with that, but I would also think about the behavior with swallowing too. So like, is he eating really fast, or trying to, being impulsive with taking too many bites in a row? Is not chewing enough? So that kind of thing might help to change the actual outcome. We might not need to cough as much, right? But that's something that I think that definitely we can assess and give some tips and strategies on.
Just to add to that, and I think it would have been a horrible idea, but when I was watching him on the beach with this, I kind of had some camera, I could make him sneeze, but obviously he's going to breathe in.
Yeah.
That was a bad idea.
Yeah.
Not a good caregiver.
Yes.
In a support group, they told me about this tube, which I ordered, that is, if you're choking, the tube is a plastic, like a whistle that pulls the food out. Is that more effective than the Heimlich?
I am not up to date on the research of that tube. I would have to look into it. I have not heard of that. I'm Heimlich trained, so that's kind of what my go-to is, but I haven't looked into any research about like a device.
Life Vac. What? We were told to get it, Life Vac.
Life Vac.
What's it called?
Life Vac. You can, Amazon has it.
Yeah, Amazon has it.
Yeah, Life Vac.
It's got like a suction. Yeah, it sucks it out. Yeah, it's like a whistle and it pulls it out.
Yeah.
Okay, my second question, we went to a speech therapist. He gave her an evaluation of my daughter has early middle stages of Huntington. And he said, what I'm going to recommend is organizational tools for you through the day. I was like, say what? And I got really happy. So is that something a speech therapist could do?
We could help with that. So the question was that someone with middle stage Huntington's disorder, they were recommended for organizational tools throughout the day. So something like that could look like a whiteboard or like a calendar on a very visible part of your house.
I know what that entails, but she can't talk.
Not a speech therapist is recommending that, exactly.
Yeah.
Mm-hmm.
Why would you do that and not help her with what you're all talking about?
So what is the specific concern?
It's hard to understand.
Hard to understand her. So that would be more so working with a speech therapist for the speech clarity and using those strategies that I had talked about with loud, slow, articulating, and pausing.
I went to him for an evaluation. That's what he came up with. It's like, what?
So that might be just a strategy that, I have a packet that I always give to everyone, and that might be part of a packet. I'm not sure why they recommended
Not typical, is it?
for that to be the only recommendation. Not typically. I give a lot of education about all the different areas that we've talked about today, and I don't really only focus on the cognitive portion. I find a lot of my focus lies in on the swallowing and speech intelligibility portion, probably because on my team, I'm very lucky to have a neuropsychologist and some great social workers that can help with some of those discussions too, along with an OT and a PT. So I kind of have the things that I focus on a lot, and it's mainly swallowing and speech. Not saying we don't talk about the cognitive portions of things, but I don't know why that person would have only recommended that. Yeah. Yeah, I don't know. Sorry about that. Yes, great question. The question was, can you recommend a chin tuck or a swallow maneuver without the use of a objective swallow assessment? And research shows really no, we shouldn't, because putting your chin down, let's say just taking that example of a chin tuck, that can actually, it can help and widen the area that, what we call the vallecula. It's a piece of, there's a piece of tissue that hangs off the back of your throat, and it kind of protects your airway a little bit, and that is called the vallecula. Putting your chin down can help widen that area, and therefore food doesn't go the wrong way as much. It can also inadvertently make you aspirate more, so we really have to see it on imaging. I would say those other strategies like a liquid wash or alternating bites and sips will probably be a little bit more safe to recommend, because that's going to be something that's a little bit more preventative compared to like in the moment trying to change the actual maneuver of the swallow. But great question. Yes.
2 questions.
Mhm. Yeah, absolutely. Great question. So the question was about, I think you said middle to late stage. Yes, middle to late stage, Huntington's disease, difficulty swallowing, having like rushing through eating and not chewing enough and coughing and choking, and their speech therapist didn't really know the ins and outs of Huntington's disease and what kind of questions to ask and how to help. I think that's kind of what, and some advice in that situation. So what I would say first is like, what's her environment when eating? Or is the TV on, anything like that? Quiet, good, perfect, A+. You always want to have a quiet environment. What about like something I always say could be cue cards, like having a picture of or a signal of slow rate of eating, alternate bites and sips. As this disease progresses, supervision and one-on-one supervision might be really, really beneficial and needed. So, hey mom, take a bite, great. Put your fork down, now take a sip. Take another bite. Oh, you don't feel like you need to take a sip? How about we take one anyway? Okay, that was a small bite. You might not need to take a sip right now. And really having that one-to-one kind of direction. And for the speech therapist, I might say, education, right? So I would tell them that the American Speech Hearing Association has really good content on Huntington's disease, in addition to, kind of the thought process of what are we changing? Are we changing anything, or are we trying to adapt? And a lot of times with Huntington's disease, we're trying to adapt, and how can we make you successful? How can we set up your environment to be successful so that we're not necessarily changing what your abilities are, right? We're matching the environment to your abilities. Does that make sense? Okay. Yeah.
I know you talked about the compensatory strategies. Sorry, can you pull that up?
Yep.
So I guess the good thing is that we're trying to do all of these, right? So we have all of these strategies in mind, and we're making sure that whenever the mom eats, like we're fighting for her. So I think she's a little bit overwhelmed trying to do all of these things, and one of the challenges when it comes to is that you can't really multitask and consider all of these things. But if I have to kind of just focus on one thing at a time, what would be kind of like the most important thing so that we can avoid the worst case scenario for choking? Would it be kind of making sure that she takes small bites, or maybe, eating slower? Like, what should we kind of prioritize within this?
Slow rate of eating, and the combination of small bites and slow rate of eating. So if you can set up the plate to be small bites at first, that takes out her decision making. She doesn't have to cut that up any further. If you can do that part and then encourage the slow rate of eating, that can really help so that she's not having to, or even something else could be like presenting smaller portions, right? So that she doesn't feel like, oh my gosh, this is such a large portion, I have to get it all down right now. So instead of like 3 meals a day that are bigger, 5 smaller meals a day, so that she feels like, okay, this is doable right now, I can get this down, I don't have to rush.
Now we have like a full bowl in front of her, and we'll take a small portion of it and have a smaller bowl in front of her. But sometimes she grabs
The big bowl.
And then she's so focused on like trying to finish it. So in that situation, should we just not let her see the bigger bowl and just give
Yeah.
her the small portion at a time and just keep refilling it?
Yeah, I think that, so the question is about having like the visual of a larger bowl that you're putting the food into a smaller bowl so it's not so visually overwhelming. And I would say, yeah, taking that bigger bowl and maybe putting it at a site so that she's not maybe like fixating on that, like, oh man, that's all for me, I have to eat all of that. Because it kind of just becomes a task, right? I need to do this and this to finish this whole task, right? So that might be helpful so that it's not as visually overwhelming.
It's funny because like she's really trying to make sure she keeps her weight, right? So whenever we do give her a small portion, and she finishes that and give her more, she gets frustrated. She's like, I'm done with my I'm doing the job I need to do, they've asked me to do, but you're giving me more, so I don't know what I'm doing wrong. She gets kind of frustrated. So we're trying to find this balance of like making sure that she eats as much as possible, but I know that at the end of the day, the most important thing is that she doesn't choke, right? She doesn't, get to this only more she has to cough and like, get to this bad situation. So we're trying to make this balance here, but I think all the information is provided. I think we can kind of start working with our therapists and make sure that she learns and kind of builds this habit rather than be overwhelmed with so many information that she has to remind herself.
Right. And I would say too that working with a dietitian can be really helpful in this time, but like, implementing like maybe inshores or protein shakes in addition to some in between meals maybe, so that you're making sure, and maybe she needs to know that too, like, hey, you're not losing weight, we're monitoring that, you're able to keep your nutrition up, you're not coughing or choking when you use these strategies. If it's taking a little bit too long for you to finish this meal and you're not satisfied yet, let's add a protein shake in tomorrow, just so that we know that we're getting some extra calories in, and maybe that'll help kind of decrease some anxieties of, am I getting enough nutrition? Yes.
You've given us a lot of like really good tips and tricks. I'm doing an education day on food and food safety. What is like your number one thing you want someone to know, someone to know about food? I know that's probably like a big loaded.
That's okay. I always say slow down, like taking your time and making sure that what you have is appropriate for you. So like being cognizant about your plate and looking at it, okay, what do I have? Oh, I see a salad. I know what I'm gonna have to grind that lettuce down really, really, really finely. Oh, there's a tomato right there. I know when I bite into it, liquid's gonna come out. I have to be ready for that. Maybe before I do that, I have someone cut up the tomato for me, right? So really just being cognizant about what's on your plate. Okay, I'm not gonna pour that dressing too much because it's very watery. That's gonna be really hard for me to navigate that in my mouth in addition to the lettuce. So just taking really good note of kind of what's in front of you and what your environment is and going slow with it. And then my soapbox is always oral care. Keep your mouth as clean as possible. That's the best way to not develop pneumonia. Yes. Okay, so the question was, at what state does someone start having trouble swallowing? And really at any time. Sometimes at the very, first symptom, or one after the very first symptom might be swallowing difficulty. That might not happen for someone ever, or maybe until the end of their disease process. It's different for everyone. So it kind of depends on what your symptoms are, and some of those things, like I had said earlier, that you're needing to watch out for, like coughing or choking or throat clearing, or like just those sensations of more effort required around meal times, is just a good indicator to talk to your doctor about it, and he can set you up with a speech therapist. Yes. So the question was recommending family members getting trained in the Heimlich. Yes, absolutely. If you're kind of, as someone who would be taking care of someone in a lot of these very medically fragile moments at times, that is definitely something that's very beneficial. And I think there might be free trainings online. I think I've ran into that before, but I think that would be a great thing for a family member to have in their belt. Just another tool in the toolbox. Any other questions? Yes. So the question was about phlegm and having, if excessive phlegm right now is an indicator that other swallowing difficulty will continue to occur or get worse. And I don't have any research to back that up or anything to back that up, but I would say, like that modified barium swallow study that I talked about, we can't see secretions in there. So we put something a radioactive chemical that is going to light up on an x-ray machine, and that doesn't get in our secretions. It's in the pudding, it's in the cracker that we're giving you. That other test that I have, FEES, fiber optic endoscopic evaluation of swallowing, that's a good test to help determine secretion management or saliva management, and we can look at that really carefully. So that might be a test that can help identify what's going on here. Is it a threat? Is it going the wrong way? Is it just that there's some saliva or phlegm that's being built up that we need to swallow extra for? Maybe an ENT visit might be appropriate too. Anything else? All right. Thank y'all.